Nanti kita kemudian akan memasuki sesi ilmiah ketiga yang menghadirkan pembicara internasional yang didukung oleh Globus Academy dan PT Fisiomedika Indonesia. Dan pada sesi kali ini saya sendiri yang akan memoderasi. Bisa langsung kita lanjutkan ya Pak Sugi ya? Oke, baik.
Lanjut.
Baik, pada sesi ini akan saya pandu menggunakan bahasa Inggris. Eh, dan bila dari teman-teman sekalian ada yang ingin ditanyakan atau ada yang tidak jelas, bisa menyampaikan di kolom chat ataupun nanti bila ada yang ingin bertanya, silahkan untuk raise hand dan berbicara langsung dengan pembicara kita. Ladies and gentlemen, good afternoon. Dear Mr. Lorenzo, we are honored to have you with us today. And we now move to our third scientific session, focusing on extracorporeal shock wave therapy in the management of calcaneal spur. And this session is supported by Globus Academy in collaboration with PT Fisiomedika Indonesia. And it is great honor for me to introduce our distinguished international speaker, Mr. Lorenzo Lusfardi Guazzoni, BSc, MSc, Product Manager, and Physiotherapist at the Globus Corporation. Mr. Guazzoni holds a Master of Science in Sport Physiotherapy from the Instituto Politécnico de Porto, Portugal, and a bachelor degree in physiotherapy from Ponte University of Applied Sciences, Netherlands. And he has extensive clinical experience in sport rehabilitation, sport injury management, and private physiotherapy practice, as well as professional involvement in sport team physiotherapy. And in his current role at Globus, he contributes to product development and international education in medical technologies, including extracorporeal shock wave therapy. And today, he will share his expertise on the clinical application of ESWT in the management of calcaneal spur. Mr. Guazzoni, are you ready?
Yes. Hello, everyone.
Okay. You will have approximately an hour for presentation and followed by 15 minutes of discussion. And Mr. Guazzoni, the floor is yours. Please kindly begin your presentation.
Thank you so much. Thank you so much, Lely, and thank you so much, everyone, for being here today. It's a pleasure for me to be here and discuss a little bit more about application of extracorporeal shockwave, specifically in calcaneal spur in the rehabilitation of athletes or sports-related rehabilitation. As Lely kindly introduced me, I have a background as a physical therapist. I've been working in many clubs and I've been working in different clinics where I've been experimenting with different technologies and different application of pathologies. Today we will focus a little bit more on the calcaneal spur and plantar fasciitis, of course, because the two are a little bit related. I will share with you my presentation so you can follow me throughout the presentation. And then, of course, we will have some questions and answer at the end of my presentation. I will try to speak slowly. I will try to be very clear with my wordings, but if there is any things that is not clear or something, please let me know so I can answer it and adjust right away. I will just now share my screen. Perfect. Great. Is it visible for everyone?
Yes, visible.
Perfect, perfect. Very well. Great. So let's start by discussing the radial shockwave therapy in the application of the calcaneal spur, specifically, as I mentioned before, in an athlete, in a sports-related condition and injury. So to give a little bit of an introduction, this presentation will aim to provide a more comprehensive clinical overview of the application of radial shockwave in the calcaneal spur, especially in the development of an athlete. So when this condition, when this injury starts to develop in our athletes. I will give a little bit of an understanding of the sports-related mechanisms of injury for this specific pathology, as well as explain a little bit of the biological aspects of this pathology in an athlete. So what is this pathology, how it is caused, and then, of course, I will present a clinical protocols with outcomes, integration of shockwave therapy, as well as we will show you some videos and some actual material regarding the applications of shockwave in this specific related injury. So to give a little bit of a brief explanation of the anatomy, as you probably all know, as physical therapists, we are professionals in the healthcare system. We study this for a long time. We have the anatomy, especially we can divide the anatomy of our foot in the in solid structure and soft tissue structures. We have in our foot, we have the bones, which are the calcaneus, the medial calcaneal tubercle, the lateral calcaneal tubercle. We have the plantar fascia, which is a fascia. We have the cuboid, navicular, and the medial longitudinal arch, which is the arch that is underneath our foot. That is also developed by the fascia and by the plantar fasciitis muscles that we have. And of course, this anatomy knowledge, it's very important for us to know when we want to apply any technologies, but specifically shockwave therapy, because we need to be very, very accurate with the positioning of our handpiece, with our applicator, and we need to know very well the anatomy aspect to be able to direct this in the correct point for the best treatment results. Then, of course, we have the adjacent structures, again, on our foot anatomy, which are more tendons and muscles, where we have the Achilles tendons insertion, which is very, very important to know when we apply shockwave therapy, especially in the calcaneus spur or plantar fasciitis. We have, of course, the two muscles of the gastrocnemius, the medial head and the lateral head, the soleus muscles, which are all related muscles when we are talking about rehabilitating our athlete, because of course any condition, but specifically calcaneus spur, it is not only local issue, but there is also an adjacent and structures related issues that of course can be caused by compensation, can be the cause of our inflammation of the plantar fasciitis or calcaneus spur, and therefore we need to assess the general adjacent structures as well as the local structures when we are rehabilitating or when we are diagnostic with our athletes. We have the tibialis posterior tendons, we have the hallucis flexors, we have the intrinsic foot muscles like the plantar muscles, and we have, of course, the medial calcaneal nerve, which is also a quite important structure to know, because of course, when we apply shockwave therapy, especially radial extracorporeal shockwave therapy, we need to be quite aware of where muscles and tendons, especially nerves, are located, because as maybe some of you already experimented shockwave in their life, it is a quite painful sensation, is a quite intense treatment. And if we go by any chance near or on top of more superficial nerves, we can cause a little bit more of a pain than actually benefit with our patients. Therefore, we need to learn and we need to know also exactly where these nerves are in the area that we would like to treat, to try to avoid them or to try to decrease the pressure or the frequency to cause less harm to our athletes in this case, but patients in general. So, of course, the pathophysiology, and these are some images of an X-ray, because calcaneus spur, it is mainly diagnosed with an X-ray. What we also need to know is that the calcaneus spur, as it's a quite known and it's a quite talked about condition, but actually it is not the main cause or the main symptom or the main pathology when we're talking about inflammation of the plantar fasciitis. Usually in an overview of X-rays within healthy individual and painful individuals, almost 90% of the population will have in an X-ray a bone spur. So we'll have this little extra piece of bone coming out from the calcaneus, but that doesn't mean that is causing pain or symptoms, okay? The bone spur actually starts to causing pain and symptoms when the plantar fasciitis start to inflame due to a different, and we will see it in a little bit, a variety of mechanism of injuries, okay? And because of the bone spur location and predominance, of course, it will cause more pain in that area instead of throughout the whole fascia plantaris. And therefore, it is known as a bone spur or a heel spur, but actually it is not the main issue that we are treating with our shockwave. What we are treating with our shockwave is the inflammation of the fascia, and of course, in some situation, in some patients, it can be caused near the bone spur. In other, can be caused in different area and different location. And also, if we have a patient coming in with an X-ray done on their foot and we have the bone spur there positioned, doesn't really mean that that bone spur is symptomatic, so it's painful, or it's causing any harm to our patient. For example, I have done an X-rays on my foot and I have a bone spur, but luckily it is not a symptomatic one, it is not active. Of course, I will start to feel it when I start to train a little bit harder or start running, or I don't have the proper footwear. I will start to feel a little bit more inflammation, but it's not the actual issue that I have. And also, some ideologically, what we are thinking that we are doing with the shockwave is try to reduce or even destroy the bone spur formation. We are actually not able to do so with our shockwave. So we are not actually destroying bone, also because if we destroy it, it needs to go somewhere, okay? And most likely they will need to do surgery if that piece break, that bone break. We are not really destroying that bone spur or making it thinner. We are actually treating the inflammation of the fascia, which is the fascia that is getting a little bit thicker and connecting and touching the bone spur and then causing friction between the bone and the fascia. And that is actually what we are treating. We are treating the thickness of the fascia more than the bone itself. Okay. So this is something really important because most of the cases, most of the situation that I had experience with my patient is that they've done an X-ray to be diagnosed with these kind of issues. We have done treatment. They felt better, they improved a lot, they were okay. They went and did another X-rays and the burn spur was still there present. And so a lot of time they were, in a sense, complaining, we have done all this treatment, but the burn spur is still there. Why is that? Because we are not getting rid of it. We are just treating the symptoms and we are treating the fascia to be able to reduce the thickness and improve their daily symptoms and their daily function. We are not getting rid of that bone spur unless we do a surgery. The only time that we can experience an actual issues of the bone spur is when the bone spur is inverted. In some cases, which is a very minimum case, very minimum incidence of cases, as you can see in the images of the X-rays, the bone spurs is going towards the finger, okay, so the toes of the foot. In very few cases, the bone spur is actually inverted. So instead of being in the direction of the toes, it's in the direction of the Achilles tendon. And in that situation, the bone spur actually start to touch and be in contact with the calcaneus nerve, which is the structure that we've seen before. And in that case, we actually need to treat the bone spur itself. And in most of the cases, it is actually required to do surgery because conservatory treatment will not fulfill the benefit or the outcome that we would like. And so in that very specific case, we will need, one way or another, unfortunately, our patient will need to go through surgery. But in 90% of the calcaneus spur injury, we have a classic heel spur, and we will need to treat it conservatively because we are treating, again, the fascia more than the actual bone itself. And in this way, of course, the shockwave therapy, it's an amazing tool, an amazing technology that we have at our disposal in order to treat this kind of situation quite quickly and fast. It will be a little bit painful for our patients. Unfortunately, that's the way it is. But the results, we will see it much, much faster than any other technique that we can possibly apply to our heel spur. So when we are talking specifically of a pathophysiology in athletes, again, normal population, they will most likely develop their plantar fasciitis or heel spur, calcaneus spur inflammation. They will develop with bad posture. They will develop with bad footwear, or when, those population that we call it the Sunday athletes, which are athletes that only go for a run or only go for a football game or only go for a training on weekends. They don't really take care of the training principle. They don't really take care of the preparation for that weekend. They just go and have fun. And those population, we can actually see a quite high presence of this kind of situation, pathology. But when we are talking about high-level athletes, performance athlete, so more than once or twice a week kind of training athletes, the main cause of this situation is a chronic tensile loading of the plantar fasciitis insertion. That, of course, will lead to microtraumas and some tissue degeneration. So we can see this actually a lot in sports that require a lot of sprinting and resting, like football, like American football, like soccer, like basketball, like futsal, like handball, like sprinting, actually track and field kind of sports, because these athletes, they're required, or they are prone to a very strong, intense, short activity, and then resting, and then again the intense activity, and it will be repeated for a longer period of time. Again, a football game is about 90 minutes, and on average, depending on the position, not a goalie, for example, but on the sides or even the forwarder, they're required to do about 6 to 8 kilometers, and they're not a steady pace kilometer. They are sprint of 160 meters repeated throughout the whole 90 minutes. And so this intense chronic overloading will cause some trauma, will cause some tissue degeneration, and will cause, of course, some micro-tearing of the fibroblast proliferation. Therefore, we will increase the inflammation. By increasing the inflammation on the plantar fasciitis, the thickness of the plantar itself will increase and will start to, again, friction against the bone, and therefore will cause these symptoms and this pain in our patients. Of course, because it's an athlete that will perform a lot of activities during the week, and they're also athletes that are used to kind of deal with a little bit of pain, with a little bit of discomfort, what they will do is most likely they will delay on the requesting assistance or requesting treatment from the health professional staff, and therefore it will cause a chronic inflammation because it goes untreated and actually goes to overload even more, even if they have a little bit of pain. And so the inflammatory mediator will start to fail the healing process, will start to get to a point where the inflammation, it is uncontrolled and it is not focused and is not precise to restore the correct healing of the tissues, and therefore more pain and more symptoms will start to accumulate, we will have an increment of fibrocartilaginous formation. Therefore, the connection or the point where the fascia touches to the bone, it will start to get a little bit harder, a little bit denser, and therefore it will not be as smooth and as tensile as fascia should be, and therefore it will cause more tension, more resistance to the motion, more rigidity to the motion of the foot. And calcium deposit will also increase, therefore it will even dense up even more. And again, all of this will develop a traction of the osteophyte, and therefore we will start to cause a lot more rigidity, a lot less motion, and rigidity that will cause a lot of pain during palpation, during walking, and of course running, jumping, and all other activities. And so when they will get to this point, which is quite delayed, then it will get tough for us. It will get quite intense for the rehabilitation process, but also will get quite painful for them. So for me, one of the main things, and we will discuss it also a little bit in the next slides, one of the main things that we really need to focus on, what we really need to want to push with our athletes, is to really communicate well and have them quite well trained and understand of asking for help right away will actually be more beneficial than delaying and thinking that it will just pass because of time, right? Again, sports-related etiology in athlete, the calcaneus formation, as I mentioned before, is mainly linked with repetitive mechanical overload, okay, more than an acute trauma. Normal population, it can even gain this kind of symptoms, this kind of problem with trauma, for example, jumping and falling the wrong way, or again, landing from whatever jump, whatever height, whatever run in the wrong way will cause also an inflammation. But in sports related, it's more caused by a repetitive overload, more than one specific symptom, one specific trauma. Of course, it kind of depends also on sports, because there are sports like track and field where we do jumping, where we do hurdles, that of course the one trauma can cause a little bit more inflammation. But again, hurdles, they're more or less 100 meters, and you have approximately 10 jumps. So of course it's a repetitive jump. And track and field also, it's quite intense on their training. So again, it's repetitive. High volume running and jumping activities, again, it is the main cause of this inflammation, especially when not well treated and well not addressed in the beginning of the inflammation. Again, one of the main reasons for it to develop is inadequate footwear and poor shock absorption. This is actually one of the main etiology, main mechanism of injury is exactly this. It's poor footwear, not enough compression, not enough shock absorption, maybe older clits, older shoes, or without the proper laces. They can cause this because, again, repetition is key. And if we start to use shoes, especially for running or especially for football, for a longer period of time, a lot of kilometers on those shoes, their shock absorption will start to reduce and their quality will also decrease, and therefore they will be more keen into generating a plantar inflammation. And also, this is caused more in younger athletes, younger population, is the altered foot mechanism, biomechanics. So when they do not have a proper or a well running technique, jumping and landing technique, when their training is quite poor on the fundamentals, they can have a little bit higher risk, higher chances on developing the plantar fasciitis or bone spur, because again, if they do not know how to land properly, they will do a lot of jumps, and they will keep landing the wrong way, keep traumatizing their foot over and over, and therefore we will cause a little bit of injury. Again, if they do not have the proper biomechanical running, they will run the wrong way. they will probably use muscles or articulation to compensate their inability. They will start to maybe push a little bit more with the wrong structures, and therefore will cause more tension and more stress on that specific point, and therefore will cause a little bit more pain. So to go a little bit further into the clinical presentation. So when we have, usually athletes are typically come to us with present progressive pain rather than a sudden onset. So they will come to you, say, I start feeling this for the past 2-3 weeks. It started to increase a little bit more in the last few days, to a point where during and after activity, I am not able to walk properly or to rest properly because the pain is too intense. But it is very rare that an athlete specifically will tell you exactly the moment that they started feeling that pain. It was that game, that jump, or it was that training, that situation, because it is a repetitive mechanism. It is overload over time. And therefore for them, they might remember it started more or less a couple of weeks ago, but they will not pinpoint an exact moment or an exact mechanism. Like, for example, when we have an ACL rupture, it was that moment I felt the pops and I fell on the floor. So this is quite common as a clinical presentation, and pain that started a while ago that is started to increase more and more during time. Usually when the athletes and we start to do our assessment, we can find a localized pain, especially in the inferomedial aspect of the heel. So when we go palpating with our foot on the calcaneus area, more or less, they will start to feel a little bit more tense and a little bit more pain, even in some situations without applying too much pressure, too much strength on the palpation. They will refer that they have a lot more pain in the first few steps during the day. So when they get up from bed, they put their foot on the floor and they start walking the first few steps. That's the most painful during the morning, right? Because again, they were not having any stress, any load on their heels, and then they start right away. And because the inflammation is quite high and it's quite a compression, it will start to feel a lot more pain in the morning. They will have, of course, increasing pain or increasing symptoms throughout their activities. It can be sprinting, can be jumping, can be different aspects of their sports, depending on their sports. But they will always tell you that the pain started to increase while we increase the level of activity, right? And again, they will have a reduced training capacity. So their performance will decrease, their capacities will decrease, and they will not have the proper ability to finish their training or to perform at the same level as they were used to before. When we want to perform a diagnosis, of course, it is primarily a clinical and supported by imaging. So, of course, all of the points that we discussed before, they are quite strong points. But if you want to have 100% confirmation of plantar fasciitis or heel spur, imaging are a necessity for us to really understand the whole situation. Palpation and tenderness, again, tenderness in palpation is a quite big indication. The windlass test, which is a test that we can also perform with our athletes to understand their level of pain and their level of discomfort. Functional pain reduction during sport-specific task. Reproduction. So whenever we ask them to do a little bit of a sprint or to do a jump or to do some sports-related at low intensity movement, they will refer to quite some pain, quite some discomfort. And again, the X-rays will confirm the spur present, and the ultrasound or echography will assess, of course, the plantar fascia thickness, which again, as I mentioned before, the two are almost always related. If we only have the X-rays to confirming the bone spur, and we do not perform an echography to confirm also the thickness of the plantar fasciitis, we can start to conduct not a wrong treatment, but not a complete treatment for our athletes. Then we're talking about conservative management. Conservative management, it's our work. It's what we do, especially in this kind of situations. The management should begin, of course, with trying to moderate or change a little bit of their loading principle and their activity. But it should never ask, especially a high performance athlete, to stop completely from training or their activity. We always need to have them participate in some kind of training. If they are football players, if they are more running athletes, we can have upper body training, we can have strength training, we can have different activity to perform with them. We just need to redesign their loading and their activity, but never ask them to fully stop. Because the moment that we fully stop, especially with the problem in the burn spur, the gastrocnemius, the calf muscles will atrophy quite quickly, and those are the muscles that takes the longest, and they are the hardest muscles to build tone and to build strength. So we will always need to try to modify their loading, but never fully stop, unless, of course, they're required to do surgery. But we are talking about conservative treatment. So temporary reduction of high impact activities, again, not fully stopping them from their activity, but to reduce a little bit their performance, their level, and to change or shift their focus to other training principles. Stretching of the plantar fasciitis and the Achilles tendons are a must, because again, we need to restore the tensile of the fascia, we need to restore the mobility of the fascia, and therefore stretching, ballistic stretching more than static stretching is actually quite needed in this situation. Then again, strengthening intrinsic and extrinsic foot muscles as well as the calf muscles. Again, as I mentioned before, the calves are the worst muscles to retrain after a period of stop. So we need to push them a lot on their training, on their activity, on that side. And then, of course, we need to focus on changing or understand their footwear to be able to fully restore not only their asymptomatic abilities, but also to avoid causing these issues more and more. Because the plantar fasciitis inflammation, especially with a burn spur, once it is diagnosed or once it is caused for the first time, they will have a much higher risk of redeveloping this kind of inflammation. And if we don't intervene on the footwear, it will cause a lot of further on issues or further on treatment needed. And then we come to we come to our specific treatment, we come to our application of extracorporeal radial shockwave. When we are talking about radial shockwave, we are talking about a non-invasive, so there's no cutting, there is no needles, there is no bypassing the skin level, okay? We are delivering high energy acoustic pressure waves, of course, to musculoskeletal tissue. Can be muscles, can be tendon, can be fascia, can be different tissues, of course, depending on the application. In this case, will be fascia and tendons, as well as muscles. We'll see after a while. The energy of the radial shockwave dispersed radially from the applicator. So whenever we are talking about the applicator, okay, so this one is the applicator of the shockwave. Whenever we are talking about applying the shockwave, the waves will start to move radially from the center of the applicator, okay? So we'll focus on this point, but we'll also treat all the surrounding areas, all the areas around that point of application. It is a little bit of a lower peak pressure compared to focus shockwave. Therefore, it is also quite safer and a better application in this kind of situation compared to focus shockwave. And the effective are superficial, especially in the plantar fasciitis disorder. So we are treating the whole inflammation of the plantar fasciitis without bypassing it without going deeper into structures that we do not want to reach or we do not want to work in that specific situation. So when we're talking again, the mechanism of action, the radio shockwave have a activation of both mechanical and biological mechanism when we are applying. So of course, the mechanical stimulation will increase the mechanotransductor of the different tissues that we are treating. We are working with the shockwave, and therefore we can increase their elasticity, we will increase their tensile force, and we will be able to reduce a lot the rigidity and a lot of that stiffness that can be caused by, in this case, the inflammation. We will, of course, also increase, and this is on the biological aspect, the blood flow and the local circulation. So the shockwave actually, one of the main aspects of the shockwave is an angiogenesis. That is the new formation of capillaries in the application area that will increase the oxygenated blood flow coming to that point. We will increase the protein secretion and production of elastin, fibroblast, and different proteins that we need to restore and regenerate the specific tissues that we are treating. Then, of course, we are first increasing the pain to then reduce the pain, right? Because again, shockwave is painful in the application, but then we work also on the nociceptors to give different input and different signals to our brain to reduce then the pain via the gate control theory. And then all of this combined, we will of course increase the stimulation of tissue regeneration and of course remodeling when we are talking about inflammation, scar tissue, or anything that needs to be remodeled after a specific injury. Why do we use radial shockwave therapy in athletes? So radial shockwave therapy, it is particularly suitable for sports-related calcaneus spur condition. We actually are performing a non-invasive treatment, which always non-invasive treatment will give us a little bit less timing because we do not have any cicatrization to go through, okay? And of course, not also cicatrization, but also time away from our sports because there is no opening wound or anything like that. It can be, again, I said it a couple of times, but it can be painful during the application, but of course, we'll have a much quicker and rapid return to sports-related activities because it is painful in those 5 minutes of application, but then the pain will actually go away quite quickly and the benefit and the pain-free stimulus will actually last for a longer period of time. It is administered always in combination with different techniques like exercise-related or manual therapy treatment to even increase their outcome, because like any devices, they do great to reach where our hands or where our exercise do not reach, so deep into the tissue. But if you don't combine with different techniques, of course, the rehabilitation will take always longer. I wish I could say that this alone will treat everything, but unfortunately, we need to have a little bit more techniques to apply to our specific footwear, especially in the bone spur, to be able to quickly have a return to sports without any loss of performance level or performance capacity. There are a lot of strong evidence-based articles and studies related to shockwave therapy, especially in fascia plantaris and bone spur treatment with amazing results. And of course, it can be again applied in combination with different technology of techniques, like in this case of plantar fasciitis, some lasers, some taker therapy, some cryotherapy, some tensile exercise, some manual work, some deep friction massage, all together to be able to restore quicker our athlete. And the beauty of this shockwave is that it doesn't really require a lot of treatment to be able to result in our athletes, but also it does not require a lot of frequencies of treatment. So usually we do between 1 to 2 treatments a week, and we have great result if, of course, in the other days we have a combination of different techniques. So those days are not rest days, there are work days, just not with shockwave. So to get a little bit more into the treatment protocol of the fascia plantaris of the calcaneus spur, we always need to adjust our application based and depending on the athlete's sensation and timing of the injuries, of course, and of course response to the application of shockwave. We never need to really push in too much pain. We need to cause some pain, but not too much pain. Okay, so we need to be able to really understand where is the line between we are causing more harm than we are causing more benefit. And this, the main way to really be sure that we are there is by following our scientific literature, following our research that describe a lot of application and a lot of parameters, especially in plantar fasciitis. And the main three parameters that we need to adjust and we need to work in our shockwave therapy are pressure, frequency, and number of shocks. Pressure is usually presented in bar, so it's the pressure, the intensity that we are applying to our compressor, and our compressor then is pushing air to our handpiece. Inside our handpiece, we have a bullet that moves up and down and will bounce against this metal applicator, and this metal applicator will be in contact with the skin, of course with a little bit of gel, and it will cause the radial shockwave. So the bar, the pressure, the higher the pressure, so the higher the bars, the more intensity we're giving to our treatment. The lower, the less intensity. And in this situation, in literature, we are describing between 1.8 all the way to 3 bar, depending in patient tolerance. And actually the bar is one of the fewer parameters, actually the only parameters in this case, that we can increase during the treatment. So we are applying a shockwave treatment, we can start with the lowest 1.8, and then slowly we can increase it up to the comfort or the response to our athletes, because our body adjusts to it. So if we start at 1.8 and we will finish at 1.8, most likely the last few thousand shocks will not be with the same intensity response to our athletes, so we can increase it throughout the treatment. Then we have the frequency. The frequency is how many times the bullet goes up and down to make it down-proof, okay? The higher the frequency, the more motion. The lower the frequency, the less motion each second. So when we are talking about 8 hertz, 15 hertz, which is the frequency more or less suggested for this kind of treatment, we are talking about 8 to 15 impulses each second. Okay, so it's quite fast. It is a quite intense movement of the bullet towards our calcaneus spur. Usually we do lower frequencies when we are in an acute stage, and we will do higher frequency when we are in a chronic or in need to destroy the inflammation process that is getting to an uncontrolled moment. So when we need to, let's say, destroy before rebuild our tissue. And lastly, we have the shocks, so the number of impulses throughout the whole session. And usually in this application, we can, in burn spur, we apply it in 2 different ways. We apply it statically and we apply it dynamically. So shockwave can be applied steady, so statically, we go to the burn spur and we treat it, or we can also move the handpiece up and down to work the whole fascia, to work the whole mechanism of the fascia, and to really work with the restoring of the elasticity and the tensile of the fascia. So usually in this kind of application, we have first between 1,500 to 2,000 impulses localized in the burn spur area, so where we have the highest point of inflammation, static. And then we can perform, again, the same number of impulses, 1.5 to 2,000 impulses dynamically throughout the whole fascia plantaris. Okay? Of course, this per session. So depending on the frequency, a session can last a few minutes. It is never a very long session, again, quite painful. And usually one session, usually one protocol, so one treatment of the plantar fasciitis, it can last between 4 to 6 session of shockwave spread between 1 or twice a week, depending, of course, on the combination of different techniques. Okay, we can do usually 1 to 2 treatments a week with many days of rest in between. We try never to do it one after the other, okay? And in between, we try to do some anti-inflammatory treatments, as well as some mobility, stretching, training, exercise, and so on, okay? Because after we apply the shockwave, we need time for our organism, for our treatment area to restore homeostasis and also to gain benefit from the application. If we apply it constantly, we will overload the system, we will overload the tissue, and actually we can cause more harm than actual benefit. Similar to when we are performing strength training and we are causing micro trauma of our muscles, we need those days of resting for the micro trauma to restore their uniformity. If we overload it again the next day and the day after and the day after, we will cause a muscle rupture in no time. So this is more or less the same principle of the shockwave.
Mr. Gozan, pardon?
Please.
Yes, just a gentle reminder, you have about 15 minutes remaining.
Perfect, amazing. So the application techniques, again, it is essential to achieve an optimal outcome. So we really need to focus and understand where to apply the shockwave and how to apply the shockwave in order to have the best results. And again, also position of the patient. So instead of reading it to you, I will show you my video, which is actually a little bit better for you to understand. Can you still see the video? Yes?
Yes, we can see. Yes.
Perfect, perfect. So when we're talking about shockwave therapy, we want to place our patient in a prone way, so belly down, have the foot hanging a little bit outside from the treatment table, and of course focus our treatment on the plantar fasciitis. Why do we want to focus it on this situation? Because we want to focus on also working a little bit of the calf muscles and also working our plantar fasciitis and our bone spur. So when we want to apply, again, here I was explaining the frequencies, the power, and the number of impulses based on the protocols preset that we have on the device, the positioning of our patient, and of course that the area of the treatment. So we want to focus on the bone spur, as well as we want to focus on the fascia plantaris, and again on the calf muscles, Achilles tendon in some ways. So when we are focusing on the calf muscles, we want to work also a little bit more dynamically, not statically. And when we are working on the plantar fasciitis itself, we want to work statically, not dynamically. So on the shockwave, we can choose the protocols that we have, preset protocols. We can go straight on to our heel spur. So we do not need to remember everything I told you before about the application, because we have here the preset protocol of averaging 2.2 bar of pressure, 10 hertz, and about 1500 impulses for the first part. And then we will repeat it on the second time dynamically on the fascia. So we can start with a little bit higher pressure if the athlete, for example, already had some treatment done previously at higher pressure, or we can start it with a little bit less pressure between 1.8 to 2 bar if it's the first time of treatment with our patient. We can deal with all of it through our tablet, so we can simply select our protocol and then working straight on with those parameters. Those parameters will be forwarded right away to our applicator, okay? And we can see it also on our applicator. And on the applicator, then we can also adjust it, and we can also adjust it during the treatment. So if you want to increase the power, decrease the pressure during the treatment, we can do it straight on from our applicator. We will focus on, so we will find the painful area, and unfortunately for our athlete, not for us, we need to apply the applicator in the most painful point, okay? So the beginning should be placed in the most painful point. Then we can work a little bit around it. We can go a little bit in fine of different painful area, but we need to first pinpoint the most painful point. And then we carry on the treatment. So we can assess it a little bit. We can put ultrasound gel. Why ultrasound gel? Ultrasound gel will, even if it's static, okay, will decrease the friction of the applicator towards the skin. So we'll also control a little bit of the temperature, will decrease the edema or bruise that we can cause by deep pressure of the handpiece. If we cause any bruises, unfortunately, it is normal. We need to tell our patient that that's a possibility, okay? Because unfortunately, it's a pneumatic hammer, so we can cause a little bit of bruises, but the ultrasound gel can help reducing that friction and therefore reducing that bruise. And then what we do is we apply it. So we apply a little bit of gel. I like to go around that area so I can then spread my applicator in that area. And again, I will go straight on to that point of pain. I can adjust the parameters, and then I'll simply press start. When I'm pinpointed, I will try to keep it in place, and then I'll just do my treatment. And it is quite painful, quite noisy also, because you have the bullet that goes up and down, and so there's a little bit of noise. It is normal. The patient can also refer a lot of pain. We should not stop unless really the patient tells you to stop. What I like to do with my athletes, with my patient, is to really have, let's say, a sort of a safe word. So if you say it's painful, I will not stop it. You need to tell me straight on, stop now. And in that moment, I understand that we are getting to a point where we are causing a little bit more harm than benefit. If I'm just looking, if you just say, oh, no, it's painful, no, it's painful, I don't care. You need to tell me straight away to stop, because it is needed to be painful. So you need to be really sure when you're telling me to stop, okay? That's something, communication is very important, and it's really specific for us to have that communication with them. And again, we will work 1,500 shots on that area. So if it's 15 hertz, more or less, I'm very bad in math, but you can do the count. It's 15 shots per second. So it's about what, a couple minutes. And then we can spread again the gel throughout the whole fascia. Okay. We will restart the protocol, which is simply just pressing again the button of the handpiece. And then we will go dynamically. So we will again start it. We will not do a lot of pressure in this case. We will simply just go up and down the fascia and really work that sensation, really work that flow of the handpiece, okay? To really focus on restoring a little bit of the relaxation, let's say, of the fascia and elasticity of the fascia, right? Really focus on that arch, really focus on the little bit more painful area. You can also mobilize it a little bit during your performance, so you can stretch a little bit the foot or relax a little bit the foot to really focus on the restoring sensation, on the restoring of that elasticity. And then in some cases, especially in athlete that has a lot more tension in their calf because they did not stop right away, we can apply it also on their gastrocnemius as well as on their Achilles tendon to really finish up the treatment by working on all the adjacent structures and really work fully with their muscles. In this situation, if you apply the shockwave on the gastrocnemius, let's try to do it after we have done exercises. Because if you perform it before we do exercises, it can cause a little bit more pain during the exercise, and therefore they will not have the same capacity or the same ability to perform their exercise, okay? And again, here we can mobilize it. We can really work that calf. We can really work that Achilles area to really focus on, we don't need to do lots of pressure. The pressure can be done by the applicator. We can increase a little bit of the bar. We really want to just to increase the angiogenesis, increase the vascular response, and reduce a little bit of that tension, reducing a little bit of that stiffness that can be caused. Okay, so let's try to do the shockwave treatment at the end of our session more than at the beginning, unless the session it is solely done of shockwave. If that day we just want to focus on shockwave, then we just do shockwave. If we want to perform any other techniques, any other condition, then let's try to focus the shockwave at the end of our treatment to not interfere with anything else. We can still do it afterwards, shockwave, a little bit of anti-inflammatory, a little bit of laser, a little bit of taker, but not too much intensity on exercises or manual work, because of course the pain of the shockwave can cause some limitation on the different applications. Perfect. And so this is a little bit off. I got perfect timings. I think 1 minute extra. I'm really bad at timing, so sorry about this. I also skipped a little bit of the contraindication or anything, but again, it's quite simple and quite easy to understand contraindication, and we also spread it a lot on the manuals. So please, if you have any questions, any doubts, I will also stop here my share screen. I'm here for you now.
Okay, thank you very much, Mr. Guazani, for the excellent presentation. And we will now proceed to the discussion session. And participants may ask questions in two ways. You may submit your question via the chat box, or you may ask directly by raising your hand first. Bagi seluruh peserta, bila ada yang ingin ditanyakan kepada Mr. Guazoni, dipersilakan.
There's always the moment where questions are a little bit less, but please ask any questions. I don't bite. There's no stupid question.
Okay. Mr. Lorenzo, may I briefly summarize your explanation in Bahasa for our participant?
Please, of course, of course.
Okay. Teman-teman semua, Bapak Ibu sekalian, tadi Mr. Guazoni sudah menyampaikan gitu ya terkait bagaimana mekanisme dari radio shock wave therapy pada kalkanial spur. Beliau memberikan contoh terutama pada kasus-kasus sport pada atlet-atlet dengan gejala klinis yang bisa diakibatkan oleh fase bertumpu yang salah pada atlet-atlet basket, atlet-atlet football gitu ya, yang terjadi kalkanial spur yang ditandai dengan gejala klinisnya tadi nyeri tumit di bagian bawah dalam di bagian inferomedia, kemudian nyeri pada saat pagi hari untuk melakukan langkah pertama, kemudian nyeri saat lari, sprint, push off, dan juga penurunan performa latihan. Tadi juga beliau menyampaikan bagaimana kita melakukan diagnosisnya, terutama klinis ada nyeri tekan media pada kalkanial tubercle, cleanliness test positif, dan nyeri saat aktivitas fungsional. Juga bagaimana penata laksanaan konservatif dasar, memodifikasi beban, kemudian melakukan stretching pelantar fascia dan asiles, kemudian strengthening otot kaki dan betis, juga modifikasi dari sepatu atau nanti menggunakan ortosis. Mekanisme kerja dari RSWT pun juga sudah disampaikan, ada mekanik dan ada biologis. Untuk mekanik tadi melakukan stimulasi jaringan dan juga mechanotransduction. Untuk biologis tadi peningkatan sirkulasi, ada angiogenesis, kemudian juga penurunan nociceptor nyeri serta stimulasi regenerasi jaringan. Dan kenapa RSWT ini cocok pada atlet? Karena non-invasif, kemudian juga setelah dilakukan treatment kembali latihan cepat dan dapat dikombinasi dengan latihan rehabilitasi lainnya. Dan yang pastinya terdapat evidence kuat pada plantar fasciitis kronis. Protokolnya pun tadi sudah disampaikan, tekanan tadi 1,8 sampai 3,0 bar, kemudian frekuensinya 8 sampai 15 Hz, Kemudian untuk area spur 1.500 shock, untuk plantar fascia 1.500 shock, dilakukan sampai 4-6 kali sesi, 1 kali per minggu. Tadi teknik aplikasi juga sudah disampaikan, ditampilkan lewat video, dan bagaimana integrasinya dengan rehabilitasi. Jadi Bapak dan Ibu sekalian, ada yang ingin ditanyakan? Silakan bila ada yang ingin bertanya. Oke, ada yang bertanya Bapak dan Ibu sekalian? Mr. Guazoni, may I ask a question to start the discussion?
Please, of course.
Okay. Okay. In clinical practice, when managing calcaneal spur in athletes, what criteria do you usually use to decide the radial shock wave therapy indicated?
Yeah, so for me, when I treat fascia plantaris or calcaneus bone spur, one of the main application or one of the main phases of my treatment, I will apply shockwave. There are very, very many evidence in support of this application in different situations of this pathology. I will not apply it when there are some contraindications, which are very, very little, like coagulation disorders, local infection or tumors in that area, open wounds in the treatment area, of course, and a very high inflammatory phase, which in the case of plantar fasciitis is quite difficult to encounter it. So I will most likely always apply shockwave. Maybe would not be the first application. I will try to do 1 or 2 treatment with hands-on. So massage, mobility, understanding a little bit more the biomechanic and exercise. And after that, if the pain is still there, of course, after 2 sessions, we cannot expect miracles. But if the pain is still there, if the situation is still acute, then I will, no matter what, apply it. What I will do is just dose a little bit more my pressure. So start with a little bit less pressure or a little bit less frequency in acute stages, and then build up with tolerance the pressure. But for me to have a very quick rehabilitation of plantar fasciitis, I'll always apply shockwave.
Okay. Bapak dan Ibu sekalian, ada yang ingin ditanyakan? Or perhaps the topic is very clear and comprehensive, Mr. Gazani.
Thank you.
Okay. Bila dari peserta ingin bertanya, boleh nanti menggunakan bahasa Indonesia. Nanti akan kita bantu untuk. Oh, okay. Any question in chat box? From Putut, from Tangerang, she asked, I'd like to ask what percentage and precision this Globus product in providing a healing effect of patient.
Sorry, can you repeat?
Okay. He like to ask what percentage and precision this global product has in providing a healing effect on patient. Yes.
So shockwave, it really depends on if it's a radial or focused shockwave. Precision can differ a little bit on these 2 technology. Radial shockwave, usually, especially our Globus device, can reach a quite deep structure, because we can go up to 5 bar of pressure, up to 20 hertz of frequency, and therefore we can actually get quite deep and quite localized. But again, radio shockwave has always, by physics, a little bit of dispersion of the wave, because the wave goes radially more than focusing on the specific structure. And usually depthness of a radio shockwave, especially Globus, can vary between 3 to 4 centimeters of depthness, depending, of course, on the parameters that we apply and on the body anatomy or composition of our patients. and it doesn't really disperse much on the structure. So we have actually a quite good effective of cavitation, localized cavitation, and in-depthness of the treatment.
Oke, bagaimana Kak Putut? Sudah bisa dipahami apa yang disampaikan oleh Mr. Gozoni? Boleh open mic? Oke.
Sudah mulai Kak.
Oke. Oke, baik. Terima kasih Pak Putut. We can understand clearly, Mr. Gozoni.
Perfect. Thank you.
Okay, and then the next questions from Husnul Indrayani from Pertamina Cirebon Hospital. He asks you, how about focus ESWT? How many power can be used? And after use ESWT, patient can running gain.
The power, so the pressure, it really depends on the patient sensation and patient, let's say, ability to withstand that kind of intensity. Usually, again, I recommend starting with a little bit lower pressure, so a little bit lower power, between 1.8 to 2 bar of pressure, and go up. It can even go up all the way to 3. The day of the treatment, okay, patients can go run or patient can go and do activity, but as I mentioned before, it is a quite intense treatment. Therefore, they can have a little bit more pain, or their level of activity will not be the same because of the pain. Usually, I always recommend my athletes, my patient, after the use of shockwave therapy, especially in plantar fasciitis, to do a little bit of strength training that day, but don't overload or overstimulate like running or jumping at high intensity or longer period of time. So always try to wait at least 1 to 2 days before they can go into their stronger training of running, right? But always depending on their phase, acute, chronic, on the intensity of the treatment, but always try to leave a little bit of day in between, because again, plantar fasciitis is a quite mechanical overload. Blind shockwave, we are overloading even more the system. If on the same day we are overloading again with some running, it can cause a little bit more than harm than actual benefits.
Oke. Kak Husnul Indrayani, sudah clear ya, semua tergantung tadi dari apakah fase akut, kronis, atau lain-lain. Bagaimana Kak Husnul? Sudah bisa dipahami Kak Husnul? Atau ada yang ingin disampaikan kembali? Oke. Saya rasa sudah paham. Oke, thank you. We can understand.
Thank you.
Okay, and then the next question, the question from Physio Hilman Muhammad Firdaus. Mau open mic, Kak Hilman? Atau langsung? He asked you about if a patient gives shockwave therapy from doctor going to physical therapist at the same day, and that mean we cannot give intervention.
No, if a patient comes to us, comes to the physical therapist, the same day that he had an intervention of shockwave from the doctor, we can definitely give treatment, give intervention, which will not give another dosage of shockwave therapy, of course, but we can do easily exercise, manual work, we can do easily different techniques, but depending also on the timings. If the patient have just completed the shockwave and 2 minutes after comes to the physio, of course, we need to adjust again a little bit of their loading of the exercises. If the patient did it in the morning and is coming to us at the end of the day, we can perform our classic intervention without any problem. We just need to be a little bit more conscious of that the patient can say that day they're not 100% able to finish the exercise or to complete their exercise pain-free because of the intervention of the shockwave. But we can definitely apply shockwave, apply intervention after they had shockwave therapy done at the doctor or even with us.
Okay. So many questions for you. And I think it is the last question. And thank you very much, Mr. Glazoni, for your clear and valuable explanation. And due to time consideration, we will conclude the discussion session. And on behalf of the committee and participants, we sincerely appreciate your sharing and expertise. And it has been a privilege to have you with us today.
Thank you so
Thank you
much.
very much, Mr. Glazoni.
Thank you so much, everyone. Thank you so much for having me. It was a pleasure. I hope I managed to share a little bit of my knowledge and application of shockwave therapy with you. And of course, if you will need anything more help, support, we have the Globus Academy, where we can see videos and materials online on different technologies, but especially the webinars of shockwave. And again, thank you so much for having me. Thank you so much for your time. It was a pleasure. I wish you a good continuation of this amazing webinar and amazing share of knowledge of shockwave.
Okay, thank you very much, Mr. Glazoni.
Thank you so much.
Oke, demikian Bapak dan Ibu sekalian, webinar kita pada hari ini. Kita sudah mulai dari siang tadi sampai sore ini dan ditutup dengan manis sekali oleh Mr. Glazoni. Di pagi tadi, di awal tadi kita sudah berbicara dengan Dadan bagaimana melakukan diagnosis menggunakan USG. Kemudian dari Pak Heru juga sudah menyampaikan tadi bagaimana menggunakan Eswt untuk tendinitis pada shoulder, dan ditutup materi disampaikan oleh Mr. Glazoni bagaimana pemberian RSWT pada atlet dengan kasus kalkanispor. Demikian, mudah-mudahan apa yang sudah kita sampaikan apa yang sudah kita terima pada hari ini bisa mendapatkan manfaat yang luas pada saat kita memberikan treatment pada pasien-pasien kita ke depannya. Demikian, terima kasih semuanya. Jangan lupa untuk peserta webinar kita untuk mengisi presensi, dan juga jangan lupa untuk mengisi evaluasi di pelataran sehat. Demikian, terima kasih sekali lagi untuk semuanya, dan terima kasih juga untuk Globus dan juga PT Visio Medica Indonesia yang sudah menjadi sponsorship pada kegiatan kita pada sore hari ini. Saya tutup, terima kasih. Have a nice day, everyone. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore.